Sir, Narun sir, you can start the meeting, sir.
Yeah.
Thank you, sir. Over to you, sir.
Thank you all for a very brief introduction. I would like to thank Redis to give me an opportunity to be here. And good afternoon, respected professors, senior consultants, and my dear friends. Even during this pandemic, in this post-lunch session, I don't want to waste much of your time, and I would like to directly enter into the session of gut dysbiosis, the role of gut microbiota in health and disease. So if you are, this is very vague area to discuss, but what is the main intention for me to do this topic right now? We all should know something about the basics of your microbiome, the basis of microbiota, what is it composed of, and what is the main role of the gut microbiota if it gets affected, in what way it is going to be involved in, what are the various pathogenesis, what are the various complications you are going to face because of this gut dysbiosis. And we all should know this microbiota is very new entity, and for the past 5 to 10 years, it has grown up very advently. So in order to know that, this microbiome right now, it has been considered as a separate organ system in a human body. So that's why, see, if you want to discuss about microbiota, it has been encompasses about all the microbiome which is being joined together. So if you are going to look into the data of microbiome, there are more than 100 trillion microbiomes are there, so far has been proven, and more than 1,000, more than 20 million genomes have been identified. More than 20,000 genomes, and more than 1,000 variant of species are there. So this is a wide area. That's why it has been considered the area of discussion as a separate organ system. And if you want to discuss about the microbiome and microbiota, the gut microbiome, the brain-gut coordination, everything is important. And moreover, when you're going to discuss, you should know who was a person who coined the term microbiota. It has been coined by Professor Liederberg a long time before. And if you're going to think about it, has been almost 10 to the power of 13 to 10 power of 14 of microbial cells. And it comprises of protozoa, archaea, eukaryotes, and also viruses. So main bacteria and viruses as well as protozoa, which is being encountered completely in this microbiota. And if you are going to look into this microbiota, there are multiple areas. It is going to be located everywhere in your body. It can be in your oral cavity, it can be in your throat, it can be in your vaginal region, it can be your lungs, it can be your skin, it can. The most important area to be located is nothing but your gut, which mainly predominantly a large bowel. So that's the area more than 70% of your microorganisms being located. And if there is any perturbation, if there is any disturbance in this area, it will predispose to gut dysbiosis, and various complications can set in. And based upon that, the management, the medications, everything has been innovated. No new advent has been coming in this field. That's very upcoming area of discussion. That's the motive for me to take this topic right now, at least to brush up your knowledge. Initial presentation, how the diversity of microbiome exists, that's my concern right now for the discussion. So if you're going to broadly categorize, it will be categorized as Firmicutes, Bacteroids, and Actinobacteriaceae. So these are all the various GI microbiota mainly composed of. So if you're going to analyze how this microbiota has been formed, means now don't think that it is going to be taken over in the later phase of life, even at birth or even before birth, when the baby is in the mother's womb. At that time itself, the microbiota process is going to be started. See, it will be varying according to the nature of birth, and whether the baby is going to be born through higher socioeconomic or lower socioeconomic, if you are living in a urban place, if you are living in a rural area, or if the baby is going to be delivered by LSCs, or if the baby is going to deliver by a normal vaginal delivery, or these are all various things which is going to influence the gut microbiota. So at the time of birth or before the time of birth itself, this microbiota is going to set in your body, and followed by the complete maturation process. It will be taking minimum, the gut-brain coordination, everything will be taking a period. The complete maturation will be completed before 2 years of age. That's the area for concern. And even if the child is going to be on breastfed, even if the baby is going to be on bottle fed or formula fed, so whatever it is, the composition is going to vary. And if the baby is going to be on formula fed, this kind of gut microbiota involvement and disturbances and perturbations and other toxicity can happen as the day goes on. So what is the role is, it will be help in resisting the pathogens and regulate the important host process. So if you're going to look into your gut, this having a wide area of density, if you're going to take your upper tract and if you're going to take your lower digestive tract, the predominant area of location will be in your lower digestive tract, and it will be going up to around 10 power 10 to 10 power 13, and it will be predominantly by bacteroids, Eubacterium, Clostridium, Ruminococcus, Bifidobacterium. There are multiple things that are see, the main intention right now is how the gut microbiome is being evaluated. I mean, how the evaluation process of gut microbiota is going to happen. So if you're going to see, you're suppose in the initial period at the time of infancy, that's what I've been discussed with you. Suppose environmental toxins, environmental exposures, based upon your diet pattern, how do you going to feed, the formula of bottle, what is the mode of delivery, as what is the antimicrobials, is there any usage of antimicrobials at the time of birth or later, or any other presentation, or during any other events when you have been used antimicrobials, or environmental tobacco smoke, I mean, or the patient is being exposed to an animal exposure. Everything is going to influence your gut microbiota, and this decides in early life development. So this has to be in a normal way without any sort of perturbations or disturbance. That has to go on. If this process is going to get involved, any disturbance, if it's going to happen, that will lead to multiple complications, not only in gut, even it can happen in your CNS, even it can happen in your liver, it can happen in your respiratory, it can happen in multiple areas of involvement. But as a gastroenterologist right now, my area to discuss with you, what are the various implications which has happened, if it happens in the gastrointestinal tract. So if you're going to see, this is what I've been discussed with you. See, your exercising is most important to regulate your gut microbiota. And if you're having any disease process, that's also will be affecting your gut problem. The disease events I'll be discussing as the slides goes on. And the diet pattern, how the diet process is going on, whether you're being vegetarian or non-vegetarian, what's the diet process you're going on, and if the patient or baby is on breastfeeding or not, the mode of delivery, and what are the drugs, the drugs that will be predisposing to antibiotic-associated complications. Some drugs will predispose to other presentation. That is one more dreadful entity that has to be addressed very strongly when you are going to discuss this presentation. See, this is nothing but simple feature, how the symbiosis is nothing but if everything is going on well. See, eubiosis is going to set in, which means there is no disturbance in your gut. The normal gut maturation is being happening, and the epithelial cells are functioning intact, and the gut microbiota is intact. That's the symbiosis, how the microbiota with the host system is being established. So if you're going to see the epithelial layers, defensive process, it will be secreting the mucus and mucin, and if you're any perturbation, if it is going to happen in that, sometimes the pathogen patterns, carbohydrate, amino acids, toxic metabolites, everything will be detoxified in this area because of the immune cells. Among the immune cells, the T regulatory cells is the most important to be concerned. And this influences our effects in various organs like our liver, brain, adipose tissue, respiratory, as well as cardiovascular, even in the gut. So for this, our pH of the nature, substrate availability, everything is going to influence the productivity of the microbiome. So this is nothing but a simple slide, how the eubiosis is happening, so if you want to discuss about eubiosis, which means which maintains the balance in the intestinal microbial ecosystem, a preponderance of beneficial species will be there. So if you're going to look into this diagram, I don't think the picture is very clear, but even then I will try to convey the concept of what has been given in this diagram. See, if you're going to see epithelium is made of tight junctions, and if it is going, suppose if we are, and it will be enclosed with the prevalence of non-pathogenic bacteria is going to be there. And if the gut is going to be disturbed by any inflammation, any toxins, anything which is going to happen, so what is going to, so there will be a alteration. So with the alterations of the tight junction process is going to break down, and the pathogens is going to secrete the lipopolysaccharide. Once the lipopolysaccharide is going to secrete, what is going to happen? The toxicity process is going to set in, and you will be releasing multiple inflammatory markers like tumor necrosis, Cox process, and INOS, interleukins. Many inflammatory markers is going to release. So the pathogenic bacteria is going to enter, and it will predispose to inflammation of your gut, which will predispose to multiple complications like IBS, IBD, whatever it is. So this is the way, even for the colorectal cancer, even for autoimmune pathology, or even for liver diseases and other complications to set it. So these are the dysbiosis. By preventing this dysbiosis to happen, our gut eubiosis has to be maintained in a good way. So how to maintain this? How eubiosis contribute yourself to your good health, which means, see, it main role, it will be exhibiting the normal immunomodulatory function, and also it will be displaying the antimicrobial, neuroprotective, and cytotoxic cytoprotective effects, and also it will be having several, mucus production, epithelial cells role, and also it will be having many, B12, folate, other vitamin complexes, many processes of other vitamins, everything will be regulated, and those metabolic process of microbiota is all, even the concepts of the role of gut microbiota is still going on for many other newer diseases also. So what are the factors which is going to contribute to this dysbiosis? So suppose if you are going to think, if you're going to take any antibiotic for a longer duration, if the antibiotic is going to distribute in the gut ecosystem, that will also contribute. And if your diet is not good, and if you're going to have a complete outside, and if you're going for a high lactose or high fermentable carbohydrates, high fat diet, that will perturb the system. And next to that, if you're severely malnourished, these are all the various external factors. And how about your sanitation practice? Where do you live? What are the coexisting infections you are having? And what about the stress pattern? Because always you should remember your stress level will always go high if the patient is having IBS, and IBS will always worsen if the stress process is going to be high. So tackling IBS is one of the most difficult entities that I'll be discussing in my latest slides. And psychological factors, stress pattern has to be taken into account strongly. And as the day goes on, if you're becoming older, so everything is going to be breakdown, your tight junctions not be made in a proper way, say everything. So as the day goes on, old age process, and if you're having any smoking or any bad habits, that will also predispose to that. And next to that, if you have type 2 diabetes, and if you are predisposing to any other metabolic syndrome, that will also worsen the scenario. So these are all the excellent factors which will contribute to the dysbiosis. And what are the internal host-related factors if the inflammatory process is not going to be maintained in a proper way, and if your gut barrier is not going to be functioning in a proper way in the mucosal, and the microbial recognition process is not going to happen regularly, it's not going to be controlled in a regular manner, and if the host defense regulation is not good, this will also predispose to gut dysbiosis. So these are all external as well as the internal factors to be taken into account to discuss something about the gut dysbiosis. So the multiple etiology, mainly to the gut focus. Right now we are going to discuss. One is because of H. pylori. As well know, it's one of the commonest organisms which will predispose to gastric malignancy, peptic ulcer disease. And next to that is IBS related presentation. And next to that is antibiotic-associated diarrhea and other complications. And next to that, if the patient is having IBD, inflammatory bowel disease. So coming to each and every area, what's the role of this gut microbiota in each and every condition to discuss about. But my intention, the most important entity, even for the gastroenterologist or even for the physicians or surgeons who is managing the patient daily, we will be getting this kind of presentation frequently in your OP also, because it's be very difficult for most of the physicians and even for the gastroenterologists to tackle this condition, because to recognize this presentation, you need to be very common, you need to counsel the patient in such a way, you need to give the medications properly, and followed by the medications also. You are not very sure whether your system, whether this condition is going to improve or not. So psychological support and other things has to be done in a proper way, and you need to diagnose this condition prior to that. And the management process is such a lengthy duration, and follow-up has to be done in a proper manner to tackle irritable bowel syndrome. So if you want to diagnose irritable bowel syndrome, your gut should not have any major pathophysiology when you're examining. See, first thing, you will be having abdominal pain. That's a characteristic presentation for most of the patients will be experiencing, and bloatedness of the abdomen, and you have any discomfort without any focus, significant organic pathology. The patient will be healthy, the nutrition status will be fine, the patient will be doing the routine physical activity, but even that, the psychological component is worsening, and early morning stress will be there, and the patient couldn't able to do the routine activities in such a way that will hinder him to have the routine life of care. So how will you categorize this very simple categorization. It can be because of constipation. Don't think that irritable bowel syndrome will always lead to diarrhea. Only it can be because of IBS-C, or it could be because of IBS diarrhea, or it could be because of mixed variant, or sometimes even subtype IBS is still more there. And if you are thinking about IBS-C, which means the hard stools will be more than 25% of your bowel involvement. And if you are thinking about IBS-D, here the hard stools will be less than 25% and the watery will be slightly high. And mixed means it will be in equal proportion. And unsubtyped means we couldn't able to categorize the patient in any of this. If you want to label the patient, see, as I discussed with you, the commonest functional. So if you want to label the patient as functional, you need to rule out a strict, strong organic focus, clinical history, assessment. That is the most important thing to manage a patient with IBS in the field of gastroenterology. So IBS is nothing but the common functional GI disorder. It can predispose to multifactorial. If always the simple thing, if a disease is multifactorial, it is very difficult to tackle. And because of dysbiosis and disruption of the intestinal barrier, it can present with abdominal pain. And main thing, what is happening for dysbiosis? Dysbiosis means the gut microbe, what is being existing, which is being completely affected. So what is the dysbiosis process which is going to happen here is the level of E. coli is going to be high, the Clostridium leptum is going to come down, and the bile acid biotransformation is not going to happen much, and the bifidobacterium levels also is going to come down. So these are all the basic bacterial focus which is going to be affected in the dysbiosis to sets in irritable bowel syndrome. As we all know that IBS is always more common in the female population. Some community variations also there, but I don't want to discuss all those things. So predominant of females is more common in India and more also in the Western population. Irritable bowel syndrome been initially diagnosed in Western places, but right now, even in India, because of diabetes, thyroid, and other complicating coexisting pathology, the presentation of IBS nowadays, even in India, it's more common. And in the West, it's almost up to 12%, and in India, it's only up to, around 4 to 5% is happening. And it's more preponderance in females. So as I discussed with you, these are all the brief symptoms, nothing much to discuss about that. The pain is a characteristic presentation, but we couldn't able to localize where is the pain. When you are going to ask the history to the patient, he'll be saying a diffuse pain, vague pain, but we couldn't able to localize. It not, suppose if you're having any pain over appendicitis, means it's very easy to localize. If you're having any, this kind of presentation, we couldn't able to localize the pain. There will be a predominant of lower abdominal pain. We are not very sure whether the right side or left side. That's a problem to identify most of the patients, and that's the history we need to diagnose. We need to ask to the patient when we want to diagnose a case of IBS. So lower abdominal pain can be the relief of pain from defecation. That's one of the most important criteria nowadays. Even Rome 4 diagnostic criteria has been taken into account. And next to that, fullness of the abdomen, incomplete evacuation. Even if you're going to the toilet, you will be spending most of the time in the toilet, but the sensation of complete evacuation of your stools will not going to happen. There will be around 60 to 70% of the patients will be experiencing incomplete evacuation, and you will be feeling mucus with stool. But one thing which I want to discuss, usually the bloody diarrhea, always alarming picture that I'll be discussing in my latest slides. But this kind of presentation, always one more thing I want to discuss. Suppose if the patient is IBS-C, he will always go for, many of the times, my professors used to say this, he may go for digital evacuation. That's the most tentative we can able to label the patient as having a functional event, because digital evacuation can be there, straining at stools will be there. So most of the adolescent age group, school-going children, or adult patients can be presenting with the preponderance to female population, rather than more, female population being more affected than males in the pathophysiology in the events of IBS. So what are the associated comorbidities of this IBS, which is going to disturb your gut microbiota? So which means mainly is a psychological component. You will be more anxious, you may be depressed, you may have somatization problem, and you may have other upper GI problems like dyspepsia, nausea, heartburn, diarrhea, and constipation. Sometimes you may have extra GI environment also, like pelvic pain, prostatitis, overactive bladder, and pain syndrome, fatigability, chronic fatigue syndrome. See, you may be wondering what is the reason you are presenting. So that's why I'm telling you, the history taking and clinical analysis is the most important if you want to diagnose this kind of presentation. So multiple disorders, multiple presentation, it can vary diverse events to diagnose this IBS-like presentation. Next to that, what is, see, if you, what is the pathophysiology behind this IBS to be established right now? To discuss is your diet pattern. That's what I've been discussing. If your diet is containing high fat, the fermentable carbohydrate load is slightly high, and if your immune system, if it is going to be altered, so in such a way, what is going to happen? Altered bacterial recognition, TLR activation. So what's going to happen? The cytokine is keeps on going to release. What's going to happen? The antimicrobial peptides, everything is going to be altered. The immune system is going to be disturbed. That's will predispose to low-grade inflammation process is going to set in, and altered intestinal physiology is also. So what's going to happen? The motility and transit. If you are diabetic, if you are thyroid, sometimes the gastric motility and transit, everything is going to be altered, and altered mucin secretion will be there. So one of the major mucin, mainly the type 2 mucin, is going to be involved in patients with irritable bowel syndrome. And next to that, increased intestinal permeability, and next to that, halted enteral neural function and hormone release. There are multiple pathophysiology for this to be discussed, and always you should remember that a stress component. If you are too much stressed, HPA activation, sympathetic activation will be there. If you are too much stressed, the bowel habit will be worsening, and you want to spend your time in the toilet. That's why you need to avoid a stress. You need to have a good sleep, enjoyable life, relaxingly convinced state of your life has to be there. That's the most important thing to tackle IBS. So if you're having unstable gut microbiota, which will predispose to gut inflammation. So what is going to happen? The host factors is completely being affected. Unstable gut microbiota will further contribute the unstable habitat. And this vicious cycle is going to set in completely to predispose you to IBS. So almost around 36% of population can encounter this kind of presentation, and will lead you to new and persistent IBS like symptoms. And if you're going to do the cultures, the common, the good commons is going to come down like lactobacilli, bifidobacterium, and facultative bacteria levels sometimes may go high like streptococcus, E. coli, anaerobes levels also may go high like Clostridium. If this is the main thing, the altered microbiota is going to happen in patients with IBS. So very important entity. This is will be discussed many of the time when we are discussing the main pathophysiology is by a twofold greater ratio of firmicutes when compared to bacteroids. This is the most important thing. The firmicutes level of bacterial focus is slightly going high rather than the bacteroids, and the twofold decrease in the bacteroids and 1.5-fold decrease in the bifidobacterium and faecalibacterium levels is going to happen. This is the main thing, and always you should remember the firmicutes level is going to be high in patient with IBS. That's one single entity if you are going to remember is enough for us to discuss today. And next to that, how will you diagnose IBS? Is nothing, no simple test is there to diagnose IBS. And always the doctor has to discuss with you multiple history, detailed analysis, complete baseline investigation. And sorry, please put the mic in mute. And some baseline investigations, and if needed, you may need a colonoscopy. Sometimes if you have any chronic diarrhea, sometimes even you may need upper GI endoscopy, because celiac disease, if you have been thinking about the celiac disease, can always mimic IBS. Even upper bowel involvement can mimic IBS. So always you should remember these are all the baseline investigations you need to do before labeling the patient as IBS, because the treatment duration for IBS is slightly longer, and the criteria to diagnose IBS is slightly different, and it has been new changes have been happened. So if you want to discuss the criteria for IBS, initially we use the Manning criteria, which is no more used much, and Rome 1, 2, the sensitivity and specificity, the ranges and values are slightly altered, and now the Rome 4 criteria has been taken into account from 2016 onwards by Lazy et al. So what's the Rome 4 criteria is going to mention in that, if you want to diagnose a patient with irritable bowel syndrome, your symptoms should be at least a period of 6 months. The activity should be at least for a period of 3 months, and the frequency of your symptoms should be at least once in a day. 1 day in a week. So at least once a day. 1 day in a week has to be there, and the duration should be around 6 months, and the activity should be around 3 months, which was not there in the initial presentation, because what was mentioned, Rome 3 criteria, the symptom frequency, at least 3 days per month, that's what they mentioned, but now it has been changed in the latest guidelines. The symptom frequency at least 1 day per week has to be there. And if so, what are the, usually you'll be getting abdominal pain, that's what, and 3 major pointers you should remember. Once you defecate, the pain definitely may possibility of the pain to come down is high, and it may be having association in the form of change in stools, and frequency of stool pattern may be altered, and these are all the things. And if you want to diagnose, you need to analyze the Bristol's chart, and complete Bristol stool chart is very easy to identify. Based upon that, you need to categorize in which categories you belongs to, IBS-C or IBS-D. So how will you approach? That's what I will discuss. You need to analyze the history. You need to see the patient pain pattern and detailed examination. And with this, we can able to diagnose the patient with IBS. And always you should remember, if you want to label the patient as IBS, you need to rule out all negative pointers. That means all the red flag signs has to be assessed properly, like worsening of symptoms after in a older age population is always alarming for everybody. So if the patient is going to present with the new onset of symptom after 50 years, you need to be very cautious, and unintentional weight loss is very riskier. And next to that, nocturnal symptoms. Nocturnal symptoms, you should remember, once the patient psychologically been, once the patient been sedated, once the patient is going to dozed out, and followed by even after that, at that point of time, the gut disturbance is still happening, which means it's a strong pointer to think against IBS, because IBS will be around usually the stress pattern, everything will be coordinating in IBS, but this is always a worrisome picture. It will be always alarming to look for features of a more troublesome picture, more troublesome entity like IBD or any other pathology to coexist. Apart from that, if the patient is having loss of blood, anemia, and if there is any family history of any malignancy in your colon, and if the patient is having celiac disease which has been diagnosed, and coexisting IBD, it's one of the most common entity. That's also one of the most red pointers to be red flag signs to be analyzed. So this is the basic diagnostic algorithm that what I have been discussed with you. So first you need to take the history, analyze the stool form, and with that you need to look for the alarming features in the next slide, and followed by the baseline investigations like ESR, CRP to look for the inflammatory marker, and thyroid function always for all, unless and otherwise proved. And next to the fecal occult blood and stool studies always to be taken into account, because sometimes stool occult blood positivity has to be there. I mean, if it's there, that's a significant point to be taken into account to rule out IBS rather than thinking of IBD or any other pathology is there. And always when you're doing a stool occult blood, make sure that the patient should be absent iron at least for a period of minimum 3 days when you're going to do a patient for stool occult blood. And do the baseline investigations. If everything is fine, the IBS diagnosis is slightly high. If anything is wrong, then and treat the patient for the primary visit and the review for alarming features. And if the patient, even after that, start the patient first line of medications. Even after that, the patient is not improving, look for a second line of diagnosis or revise your diagnosis. So how will you manage? There's a huge list of drugs for that. That's not the intention for me to discuss today. Suppose if you want a patient to be managed with IBS, either it could be diarrhea, multiple antidiarrheals are there. If you want to tackle a patient with constipation, there are newer medications, many medications are there in the field of gastro. And next to that, the pain management, antispasmodics, and many things are there. But my concern to discuss something about probiotics today, because probiotics is having a role everywhere, and the gut disturbance is mainly by the gut. What is this probiotic? That's the area for me to discuss. And if before concluding about this, regarding the management of IBS, that's what I've been discussed. Huge line of, you can use FMT, that's a fecal microbiota transplant. It's a new entity to be tackled right now. It can be used in multiple entities, IBD and IBS, even for alcoholic liver disease. Many areas where we are trying this, and many centers in India, they've been trying this modality of treatment, but still need more studies to validate this kind of things in India. And apart from that, dietary interventions, always you should follow a low FODMAP diet, which means fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Everything has to be reduced. In this low FODMAP is the most important pattern if you are going for a diet management in your patient with IBS. And list of probiotics, list of symbiotics, list of prebiotics is there. Those major definitions I'll be discussing in my next slides. And next to that, newer drugs like rifaximin, other things also can be tried. Apart from the linaclotide, it's guanylate cyclase activated, newer drugs for constipation, other things is there to think in terms of management. But What are the other areas in which the gut dysbiosis is going to happen? It's nothing but inflammatory bowel disease. If you want to discuss about inflammatory, it's very huge area to be discussed. IBD, two major entities, one is UC and Crohn's. Always you should remember Crohn's will be predominantly everywhere in your GI tract. It can happen from mouth to anus anywhere, but UC predominantly in the lower GI. And next to that, always you should remember that if you are thinking about IBD, usually a multifactorial, which means you couldn't able to diagnose the proper etiology. It can be because of your gut dysbiosis, or it could be because of your infective process, or it could be because of your genetic origin. It could be a multiple variant, but any of the final gut disturbances and perturbation of its regular activities has to be affected to prove, and by colonoscopic confirmation you can do IBD. A final conclusion can be made. And usual presentation for IBD is a bloody diarrhea. Abdominal pain is very characteristic. Sometimes doesn't mean that always bloody diarrhea has to be there. Sometimes I have seen, even in my experience, I have seen some patients even without bloody diarrhea. We have many times been presented, but always you should remember even small bowel events can be there in IBD also, provided if you are suspecting a Crohn's disease. And next to that, the main dysbiotic features like Enterobacteriaceae level may go high, and Ruminococcus levels may go high, and butyrate organisms, butyrate producing is one of the most important things. Not just butyrate producing organism, it is going to go down, like Faecalibacterium plasmodium. That's the main pathophysiology in the discussion of Crohn's and UC. And these all of the things will be affected if in the pathophysiology of IBD. And next to that, a few points about antibiotic-associated diarrhea. Always you have to well remember that multiple antibiotics are there, huge list, even starting from amoxicillin to cephalosporin, huge list of antibiotics to cause this AAD. And we are tackling, sometimes you should remember that AAD can present you with fulminant colitis. Fulminant colitis, if it going to happen, that's completely going to disrupt your gut, and you may have bloody diarrhea, worsening complications, and sometimes you may need intensive care treatment. And sometimes even for antibiotic-associated diarrhea, the other line of care like newer generation of oral vancomycin and other things can be considered in the management. And dysbiosis, if it's going to set in, sometimes even FMT is being tried in the management of AAD. And next to that, H.pylori infection, that's what the main concern for us. And apart from the H.pylori, many patients have been diagnosed with this. If the patient is going to have peptic ulcer, if the patient is going to present dyspeptic symptoms for a longer duration, the gastric dysbiosis is going to be affected. And almost if you're going to, the main reason is mainly because of the bacterial diversity alteration, and proteobacterial level is going to be high, and Firmicutes is going to be high, and Bacteroides is going to be high, and Streptococcus is going to be detected more common in gut, in your gastric system after H. pylori. So what is this probiotic? So what is its role to improve your gut dysbiosis? That's the main intention for me to discuss now. So what is this probiotic? Which is nothing but if you're going to substitute a patient with a living microorganism, that is going to confer some health benefits to your host system. So that is nothing but it's a probiotic. If you want to categorize, always remember a few simple things about probiotics. Always probiotic is when you're discussing something, you should remember about prebiotics. Prebiotic means nothing but it's a non-digestible carbohydrate. And when you're going to substitute this patient, is going to augment the effect of probiotic. Also, it is going to affect the host system in a successful way. And next to that is symbiotic, which means it's a combination of pro and prebiotic. And what is this probiotic? What is this composition? What are the various types of probiotic? Multiple types are there. And next to that, what is its role? How does it act? And how will you choose a probiotic? Suppose if you want to choose a probiotic, it has to fulfill certain characteristics as per WHO. So the probiotic characteristics has to be well maintained. So that I'll be discussing with you. And see, always when you're substituting the patient with a probiotic, you need to improve the gut microflora. Always you should remember that. And pathogenic microorganisms has to be targeted. And next to that, it should have a direct protective effect in your gut. And the increased tolerability has to be there. And so if you want to discuss about the history of probiotic, which was long time before 1900, so the Professor Elie Metchnikoff has been the major Pasteur Institute from this great scientist who was the first person to conceptualize this probiotic. So if you want to think about this probiotic, there are certain key properties has to be addressed strongly. That's what I've been discussed with you. The key properties, the role of action, and how does it act, and what is the probiotic of choice in which condition you are going to treat, because there are probiotic even for malignancy, there are probiotic even for respiratory, even for a gynecological issue. There is probiotic for all the problems. So our target, what is the organisms you are going to target, and next to that, how does it going to improve the function of your gut and other systems. So if you want to choose a patient with probiotic, it should be a non-pathogenic focus, and it should not be toxic, and it should not be having any allergic compounds. And next to that, it has to survive and metabolize in your upper tract, and predominantly it has to resist your pH and organic acids. And when this probiotic, if it is going to survive in your colon, it has to cross the bile pathway, it has to cross the gastric pathway. So everything it has to be crossed. When it is going to be in your colon, at least 20 to 30% of the viable probiotic has to be there to fulfill its mechanism action. And always you should remember, all the probiotics is not going to do that. All the probiotics which is available in the market is not going to ensure all the things. There are certain list of probiotics in the domain of gastroenterologist that has to be done in a proper way based upon the clinical presentation. And it should be always a human origin, and it should be genetically stable and capable of maintaining capable of remaining viable for a longer periods of time, and able to modulate your immune system, which means it can able to modulate your immune system and provide resistance to multiple diseases, and to improve immunity, to the production of antimicrobial substance in the gut. There are multiple antimicrobial substances can be released that we'll be discussing with you. So it will be provide a good adhesion, colonization features, antagonistic against carcinogenesis, and these are all the multiple modalities for which the probiotic characteristics has to be ensured. Next to that, so what are the various established effects of probiotics? I mean, it can be used in multiple conditions. As I discussed with you, antibiotic-associated diarrhea, it can be in IBD, IBS, and other presentation, even for anticolon effects, even for the cardiac protection, even for the hypertension, even for the gynecological and respiratory issues. There are multiple roles for the probiotic, even in infancy period, even for the acute gastroenteritis, there are many roles, even for the lactose intolerance can be considered. So in which condition you are going to tackle, that's the most important. This is how the probiotic, the purported mechanism pathway, who does it going to act. If you're going to see this probiotic, it's going to inhibit the pathogen producing organisms. I mean, pathogen produced microorganisms by producing lactic acid, bacteriocins. There are the various defensive pathways are being going to be released if you're going to take this kind of probiotic, and it competitively exclude the enteric pathogens and cytokine synthesis from the enterocytes, which is going to be released, and it will be adhering to the surface, attaching to the surface, which will provide the immunity focus, and also the production of butyric acid, which increases the turnover of your enterocytes, the gut maturity. The gut process will become, the denuded gut problems is going to be resolved, and the neutralization of the dietary carcinogens. If you are having a dietary carcinogens, there is high possibility for this probiotics to get neutralized. So what are the various advantages and what are the various mechanisms? There are so many things. It can be acted by defense, it can be acted by natural killer cell pathway, it can act by tumor, T helper cell pathway. There are many pathways, around 12 to 15 pathways are there. That's not the intention for me to discuss. If you are going to remember the few points about probiotics, which means it produces lactic acid, which means, so what's going to happen? The main organism like Clostridium, Salmonella, the vulnerable organism level is definitely going to come down, like Shigella, one most dreadful entity for predisposing to hemorrhagic gastroenteritis. And next to that, it will also decrease the production of very toxic and carcinogenic metabolites, and aid in absorption of minerals, especially calcium, and increase the intestinal acidity levels. And next to that, beta-galactosidase, which means the main enzymatic focus, there are many conditions to be used, and also many antimicrobial substances going to release, like organic acids, bacteriocins, acidophilin, lipofilin. Many compounds is going to be released by this probiotic. And as I discussed with you initially, the acting on vitamin B12, folate, multiple vitamin pathways is going to involve. This is how the probiotic is being doing wonders in managing the various diseases. And if you want to categorize probiotic, it will be a bacterial derivative, it can be yeast derivative, and yeast derivative nowadays slightly having more potent when compared to bacterial derivative. That's what. And next to that, bacterial focus like bifidobacterium. How will you categorize that? Which can be bifidobacterium, it can be lactobacillus, or it could be bifidobacterium infantum longus, lactobacillus brevi, and so many other compounds of that. It could be because of Saccharomyces in the yeast formulation, or even could be LRGG. Many probiotics are there to be discussed, and not all the probiotics is the same, because always you should remember it has to resist the gastric, the bile acid, and when it reaches the colon, it has to go around 20 to 30%, and 93% were incorrectly labeled most of the time, and 50% of the probiotic may add contaminants, additions to the strains on label, and more than 35% were missing one of the species which has been claimed in the label. So it can be variant specific, and always the cocktail of probiotics usually I will not be recommending, rather than targeting one single probiotic to a particular focus, the particular thing which is being concerned. That's what a yeast found slightly having more effect when compared to the bacterial probiotic, which means the viability in GI environment is not going to be affected when you're going to use the yeast formulations, and acquisition of resistance will not be there, and antibiotic usage naturally resistant if you're going to use a yeast formulation, and the interaction with the normal gut microbiota usually will not happen if you're going to use yeast formulation. And next to that, that's what I've been discussed now. If you want to discuss about how the probiotic is going to survive in your GI tract, which means it has to tolerate the acid secreted in your stomach, it has to cross the bile acid pathway, and by the pancreatic juice secretion, everything it has to cross, and at least around 10 to 15, 20% or 25% of the probiotic has to be there to survive in the colon to produce significant effect of your gut microbiota to exist, which means after minimum period of 60 minutes to 90 minutes, this process has to be there, and the survival rate has to be at least 20%. Why is survival important? Because only live bacteria can produce antimicrobial compounds. That is the most important to replenish your gut dysbiosis. And next to that, adhering to the intestinal wall and prevent pathogens from adhering. That's the most important. And secondly, multiple compounds which will improve the intestinal epithelial cells, and also it will be reducing the inflammatory pathway, and it will consume nutrients necessary for all the pathogens to survive. So live probiotics are the usual essential ones for best outcomes. And so some few points about Saccharomyces boulardii, that is also the yeast derivative form. It will be used for multiple entities like antibiotic-associated diarrhea, or IBD, or it could be even for the necrotizing enterocolitis, or even for multiple events, which is being used even in pediatric age group, or even in the older patient, or even for the prevention of colorectal pathology or H.pylori infection, because this Saccharomyces boulardii also can be considered when you're going to think about the management of probiotic. So before concluding the key take-home message, the gut dysbiosis is always ready to set in earlier. Always when you're taking the tablet, you need to be very cautious. Depends upon your presentation, you need to be very, very cautious, and followed by you need to consult the gastroenterologist. What is the presentation you are having? And next to that, what is the etiology has been diagnosed, whether it is H.pylori or AAD or acute diarrhea, IBS or IBD. Based upon that, we need to target the organism or any other thing is there, obesity. Also, these are all the various coexisting pictures. Sometimes if you are having autoimmune pathology, and sometimes if you are going to have a liver disease, there are a list of probiotics and various conditions. Before concluding, I would like to tell one important word during this pandemic, because you should remember that always the probiotic, always the gut microbiome will be going with your brain. Okay, that's the gut microbiome axis. The brain gut axis will be there. So if there is any disturbance in your brain, it will affect your gut. If there is any disturbance in your gut, it will affect your brain, because all the major pathways are being interlinked. That's why your mind has to be happy to make your gut as to be healthy. And if your gut is healthy, your mind obviously will be happy. And always you should remember that gut microbiota is the role of an astronomy. So if you're going to see that as an astronomy, the gut microbiota has been focused on the trillions of things which is being happening in the astronomy, and you should always accept that the gut microbiota role has to be established in a very good way, and respect your microbes, and take care of your health, and have a good diet, do a regular physical activity, and if you want to lead a healthy life, take care of the bugs which is being happening inside to prevent the gut dysbiosis to be happen.